presenting cells. So the advantage is there's actually less afferent presentation of antigen to the area, and there are no post-capillary venules to allow effector cells to be more efficient there. So it preserves the corneal clarity. The peripheral, so the peripheral corneal limb is vascularized and does have more antigen-presenting cells. Okay? But in addition to these sort of structural things, there's another mechanism called effector blockade, which the corneal endothelium has properties. It's exposed to the aqueous humor, which has immunoregulatory proteins in it, but the corneal endothelium itself has its own protective mechanisms, one of which is called Fas ligand, which I'll explain to you a little bit later in this talk. So how does this bear for you guys in clinical practice? Well, if you think about cornea transplants, right, what increases the likelihood of rejection for cornea transplants? Well, we think if you've had multiple corneal transplants. So why would that be? Well, if you're exposing the immune system to foreign antigen repeatedly, you're going to increase the response. Likewise, if you have neovascularization, right, you now have disrupted this immune microenvironment of the central cornea, and you've made it more like the limbus. So now you have more immune cells coming in, and you're more likely to get rejection there. It's the same reason why we try not to make the graft limbus to limbus if we can help it, right? We try to make it a little bit smaller, so it still provides optical clarity, but you're not reaching all the way out into the limbus to attract those immune cells. Interestingly, cornea transplant enjoys, I think, one of the highest rates of acceptance of any organ transplant, right? Over 90% of first cornea transplants are going to be accepted by the host over the first year. That's not found in almost any other organ transplant, and it's especially amazing because we don't do MHC typing, we don't put patients on strong immunosuppressive medications for acceptance of the graft. The anterior chamber, aqueous humor, and the uvea are slightly different. And there is a partial blood ocular barrier, and this is usually through fenestrated capillaries within the ciliary body. These allow the diffusion of some macromolecules into these tissues, but generally they're smaller macromolecules, and as you get larger, there's less chance of them diffusing out into the tissue. But there's also tight junctions between the pigmented and non-pigmented ciliary epithelium. And so that prevents a lot of these molecules or reduces their diffusion into the anterior chamber. Likewise, the aqueous humor, as I've mentioned before, has immunoregulatory cytokines. It also has neuropeptides like alpha-MSH and somatostatin, and it also has complement inhibitors. So all of these things are circulating within the aqueous humor environment and prevent or immunoregulate and reduce and tamp down the immune response in those tissues. There are very few immune cells in the anterior uvea. There's a few T cells and some mast cells, but otherwise, most of the antigen-presenting cells are actually located in the iris of the ciliary body. There's probably little local immune processing here. Most of these antigen-presenting cells will go through the venous circulation and then be processed elsewhere. One of the best ways that we have to study the immune privilege of the eye is a system called the anterior chamber associated immune deviation. And what this is we inject a little bit of antigen into the anterior chamber. Normally, if you inject antigen under the skin, what happens? We get a delayed type hypersensitivity response, right? You guys think of like about a PPD, for instance. If you inject that same antigen into the anterior chamber, you'll get a robust antibody response, but it will actually tamp down the delayed type hypersensitivity response. And what you can have is even in animals who have a delayed type hypersensitivity response to the antigen, if you then inject it in the anterior chamber, you can suppress that response later. And so how does this occur, or how does it happen? Well, we think that the antigen gets accepted by these antigen-presenting cells within the iris and ciliary body. They migrate through venous circulation, both to the thymus and the spleen, where they then produce effector blockade. Right? So they're going to produce these cells, or regulatory T cells, that will then suppress the immune response. But in addition to this production of T cells, regulatory T cells, we're also going to have the immune environment actually reduces the effectiveness of the normal immune system there. And one of the ways it does that is through, there's probably multiple mechanisms, but the best studied one is through Fas ligand. And so Fas ligand, when lymphocytes that have a Fas receptor attach to Fas ligand, then it induces apoptosis in those cells. And part of the diagram, and I'm sorry, this is the last diagram like this that I'll show you guys, but I just thought it was interesting because scientists are pretty creative, and so you have the naming of some of these things is pretty cool. There's the RIP for receptor and executioner capsases, all for apoptosis. So I thought it was kind of cool. So what's the role of the vitreous here? So we're not sure, but we think that the vitreous probably is more biologically active than we had previously thought. When we do proteomic analysis, we find that there are proteins both from outside the eye as well as from inside the eye, and that the vitreous itself can electrostatically bind charged proteins, charged particles, and it can also serve as a scaffold for leukocyte adhesion. So again, bringing this back to our clinical perspective, if you have patients, where does this come into play, right? So if we have patients with intermediate uveitis or vitritis, what role does the vitreous have in prolonging or magnifying that inflammation? Well, years ago, I think it was Hank Kaplan was one of the biggest proponents of doing vitrectomy for the patients, right? Taking it out. And I think that lost a little bit of favor and came out of fashion when we had immunosuppressive medications, and everybody thought, well, that's sort of like the barbers, bleeding patients for bad humor. It probably doesn't do anything. But we have recent data, I believe from Indiana, that shows that if you do a vitrectomy, it actually augments the effect of immunosuppression in those patients. So there's definitely some benefit, I think, to removing the vitreous in some of those patients. The figure on the right, the retina folks here at Stanford, I'm sure, are good enough that they never see anything like this. But this is proliferative vitreoretinopathy. And it's thought that the vitreous plays a role. The main effector cell in this is RPE cells. And they sort of migrate out into the vitreous, they start contracting, and they pull it, and you'll get these chronic retinal detachments. It becomes very difficult to treat. And we think that the vitreous plays a role in that in stimulating the RPE. When you have a break, that the vitreous contact with the RPE then may stimulate proliferative vitreoretinopathy. Within the retina and the choroid, it's a little bit less understood. So there is a blood-ocular barrier, and we know that there are tight junctions in the endothelium within the retinal vessels. That provides a blood-ocular barrier. There's also tight junctions between the RPE and that provide a barrier between the choroid and the retina. But beyond that, we really don't have much data. We do know that RPE cells, they can affect or downregulate T helper 1 subset of cells, so they can regulate the immune system a little bit. They can also increase the production of T regulatory cells. Interestingly, there's a form of immune privilege that's similar to the ACADE system. If you inject foreign substance beneath the retina, it has a much higher rate of acceptance. And so this comes into play with stem cells, and also recently with the use of genetic gene therapy, so adenovirus. I think the rate of rejection for that is only about 5% in the studies. So this provides a very unique environment where I think we'll really be able to do a lot by using this space to deliver drug therapy or stem cell therapy. So again, remember that the eye is an immune privileged organ, and along with the brain, the testes, and the placenta, as well as the fetus as well. But this provides an evolutionary advantage. So again, think of it in that context. It's based on both the passive microenvironment, so there are certainly barriers to the immune system entering these tissues, but there's also an active suppression of the immunologic phenomena in those tissues as well. And they can be overcome, it's not absolute. The ACADE system is probably our best understood model for immune privilege in the eye, but again, it's just a model. We don't know exactly how this pertains to humans, but Fas ligand probably plays an important role there. So I'll end the talk on immune privilege there. If there are any you want me to take questions or leave them to the end, or if there are any questions? Perfect. Okay, so I'm going to move on to the second half of this talk, which is what is uveitis, classification and nomenclature. Again, not the most exciting title, but I'll try to bring it up to you guys clinically. So if you look up here, and the writing's intentionally small because I'm supposed to read it, but there's just a number of different diagnoses that are included within uveitis, right? And so if you just look at the Will's manual or you look at something, they're going to give you a list of tests a mile long, and you want to order them on every single patient. So how are we going to organize our framework? How are we going to think about uveitis in order to help narrow down the differential and better treat our patients? Well, one way is through classifying these uveitis in terms of anatomic location. And so in 2005, a group of uveitis specialists, I'm sure some of them are in this room as well, got together in a working group in order to try to come up with a standardized nomenclature for us to talk about uveitis. And the original goal of this paper, really, was for us to be able to do research. So if someone presents a case series about anterior uveitis, and someone wants to compare their case series of anterior uveitis, you should be able to compare them. You should both be talking about the same condition in order to be able to compare them effectively. And so that was part of the impetus for this. It wasn't necessarily brought up as a clinical tool. It was more of a research tool. But many of the uveitis specialists, because we're involved in research and even otherwise, we've adopted this standard nomenclature. So the important thing here is that the way that we address uveitis is based on the primary site of inflammation, not on structural complications. And so the reason that I have a picture of the OCT of CME here, if you have anterior uveitis with CME, that's not pan-uveitis all of a sudden. It's not posterior uveitis because there's macular edema. The macular edema is a structural complication. You have to look at the central area or the primary site of inflammation. So if it's in the anterior chamber, iritis, iridocyclitis, anterior cyclitis, vitreous is intermediate uveitis. We look at pars planitis as a subset of intermediate uveitis that has no systemic disease association. Posterior uveitis should include retinal or choroidal lesions. It's unclear. I think we were unable to agree on where retinal vasculitis fits into that, other than to say that retinal vasculitis by itself probably can't be a diagnostic feature on its own. And panuveitis includes inflammation in all layers. In situations where you have inflammation more than one layer, so say intermediate uveitis with some cell in the anterior chamber, you're going to look for where there's more inflammation. And if there's predominantly more inflammation in one chamber than another, then usually it's spillover from that chamber into the other. So for instance, intermediate uveitis, if there's 3+ cell in the vitreous, 1+ cell in the AC, it may be spillover into the anterior chamber. It's 3+ cell in the anterior chamber, and there's 1+ cell in the anterior vitreous, it's probably spillover the other way, and it's a primary anterior uveitis. So this situation, this is an oblique view through the cornea and the lens. Obviously, this is some vitreous stranding here. This is what we would call intermediate uveitis. And again, how does that help us with our clinical diagnosis? Here's our whole list of diagnoses here for different types of uveitis. But if we look at intermediate uveitis, now that we've classified it, we can narrow that down right away. And even among these differential diagnoses, these are going to be narrowed down further by your history, right? If someone doesn't come from a Lyme endemic area, you're unlikely to test for Lyme disease. Similarly, if you might not look for intraocular lymphoma in a very young patient. I'll skip this slide here. In addition to that, we looked at the we looked at descriptors of onset, duration, and course. So if we need to establish whether the inflammation is sudden in the onset or insidious, sort of slowly creeping. We need to also look at duration. If it's limited, it's usually less than or equal to 3 months duration. If it's more persistent, it's greater than 3 months. And course, acute, recurrent, or chronic. Okay? And the key here is the 3-month duration. So again, chronic inflammation looks at persistent uveitis with a relapse within 3 months of stopping medication, or if they relapse while they're still on medication as you're tapering. Recurrent disease were repeated episodes with more than 3 months in between them, and acute was sort of the single first episode there, or a single episode on its own. So how does this help us? Well, if we look at onset, right, HLA-B27 uveitis is more likely to be sudden in onset. Sarcoidosis, juvenile idiopathic arthritis-associated uveitis is more likely to be insidious in onset. And the symptoms that the patient will tell you for anterior uveitis, for instance, may be different. For sudden onset, they might say, I have pain, redness, photophobia. But in patients with insidious onset, they might just notice, well, the eyes have been a little red, or I've been noticing my vision declining progressively. When you see patients in the clinic and they come to you anterior uveitis, first episode, I think most of the specialists here will agree that all patients with uveitis should be worked up, even the first episode. But in the US, 50% of those anterior uveitis are probably going to be HLA-B27 positive. That percentage, the likelihood increases if it's recurrent disease. And if it's recurrent acute alternating anterior uveitis, the chance is very high that they're going to be HLA-B27 positive. Okay? So again, you can almost make the diagnosis without doing any blood tests. Just talking to the patient, figuring out what the history is, will give you some of your diagnoses right there. Tubular interstitial nephritis with uveitis syndrome, similarly, at a study, I believe this came out of Oregon, where they took all of their patients with uveitis, only about 1% had TINU. If you then subdivided that into patients with sudden onset bilateral uveitis, it increased. If you said bilateral uveitis in young patients, the percentage increased. And then if you got to bilateral uveitis in females under 20, they had a much higher rate of TINU in those patients. So it'll help you direct your investigations. Anatomic location and the course will often dictate treatment as well. So for instance, if it's primarily an anterior uveitis, you might be able to use just either topical or regional steroids to treat those patients, right? But if it's intermediate or posterior uveitis, then you're going to be looking more at regional steroids or systemic therapy. And if the disease is acute and recurrent, episodic, you should be able to treat them within each episode without having a significant loss in vision. But if it's chronic, then those patients, for instance, patients with, and I'll go with anterior uveitis, so that's maybe what you probably will see most often, but patients with anterior uveitis, if they keep flaring up within a couple months after you taper the drops, don't keep tapering them off the drops, right? You keep them on the lowest dose necessary to keep them under control, or you switch them to immunosuppressive medication. The Sun classification also looked at grading inflammation, right? And so don't worry about this too much, but there are scales by which we'll grade inflammation. I'm sure if you're in Kwan's clinic, he'll go over these with you, and I'm sure you have a posted vitreous haze scale in every room, right? But you'll look at vitreous haze, you'll look at anterior chamber cell and anterior chamber flare. And the nice thing about this is the scales have actually been shown to be pretty consistent even between observers. Especially if you expand it to within one grade, so you might say 2+, I might say 1+, that our agreement is going to be pretty similar within that grade. It's unlikely that you're going to say it's 4+ and I'll say it's 1+. So again, classification based on the Sun criteria, it allows us reproducibility for studies, but also helps us in our differential, and it also helps us to think about a framework with which to treat patients. Okay, thanks very much.
So I have known Dr. Sanjay Kedha for over 20 years now when we start training together at Hopkins, and this is the first time I saw one of those blood-shooting reptile thing that he just picked up the gate here. So before we get in, any question for Dr. Kedha at all? No? Okay. If not, I think this is a course, right? So you have the right to ask question, and in fact, they will also ask you question too, and we're going to aim at some of our Stanford residents and then this Stanford colleague here. So any other question? No question? Okay. So we're going to move forward with the next presenter.